Hi, I'm Mohamad Mohty from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And I've been asked today to discuss the potential use of a high-dose post-cyclophosphamide versus ATG for GvHD prophylaxis. I think in the last 10 years or so, we've seen some really impressive results which could prove that high-dose post-cyclophosphamide infused around days 3 and 4 after the stem cell infusion can allow for some potent GvHD prophylaxis without impairing engraftment. And this was proven to be true in the haploidentical setting. And thanks to the pioneering work from Hopkins, I think now this POSCI platform has become a standard of care in the haplo setting, but is also progressively becoming a backbone for GvHD prophylaxis beyond the haplo transplant setting. And because if POSCI is so potent in the haplo setting, why can't you use it in other transplant setting? And one question is about the unrelated mismatched setting, mismatched donor setting. And we don't have yet randomized trials. However, the data from the EBMT registry published in 2019 in Blood by Dr. Battipaglia and colleagues could show, despite the limitations of a retrospective study, that POSCI is likely superior to ATG in terms of GvHD prophylaxis when it comes to the mismatched unrelated donor. However, the picture is slightly more complex when you compare POSCI to ATG if using a matched sibling donor or a fully matched 10 out of 10 unrelated donor. And here, based on retrospective data from EBMT, but also based on prospective data, randomized phase 2 trial presented by Dr. Brissot and colleagues, actually, we don't see a superiority of POSCI over ATG. So it looks like that when you are dealing with a fully matched donor, both options, ATG and POSCI, are behaving and are yielding some good results. So the question, what to do next with all of this? And my feeling, and this is the work of several teams started to do this, is why not combining low dose ATG, but also POSCI, full dose, but maybe later lower doses, in order to further, I think, improve GvHD control, especially that the initial experience with POSCI has been generated using unmanipulated bone marrow. However, now the most frequent use is about peripheral blood stem cells. And with peripheral blood stem cells, actually, the incidence of chronic, especially extensive chronic GvHD is higher. So this is why I think a mixture, a combination, trying to fine-tune a low dose of ATG and POSCI, in my opinion, would be a very promising strategy. And we are eagerly waiting for the large studies, but the preliminary data from single center and smaller series are already very appealing. So I think this field of GvHD is moving really nicely in the right direction, not only in terms of GvHD treatment, because we've heard about the different approved drugs recently when it comes to refractory acute or refractory chronic GvHD, but also in terms of GvHD prevention. And this is really good news because it will allow to make allotransplant a safer and safer treatment approach for all those patients who are in need.